Hi, I'm Jonah Comstock, Editor-in-Chief at PharmaForum. I'm here at ASCO 24. It's Sunday. I'm joined by Paul Burton, Chief Medical Officer at Amgen. Dr. Paul Burton, right?
Absolutely. Amgen.
So, Dr. Burton, thank you so much for joining me today. Talk to me about what Amgen is here at the conference to present. I know you've got like 16 abstracts, but two kind of ones that you're highlighting, both in lung cancer, right?
Yeah, that's right. So Amgen's been in oncology for 40 years. 1 in 5 patients with cancer will receive an Amgen medicine. So we're thrilled to be here at ASCO. Two big buckets of work, I think, for us here. One around Lumakras, and the other around our BiTE program, our bispecific T-cell engagers, particularly tarlatamab. And we have lung cancer data in both of those.
So let's do them one at a time. Let's start with the first one you mentioned.
Yeah, so Lumakras, our G12C KRAS inhibitor. We have two big pieces of work. One is a small phase 1b study going into early line use in patients with non-small cell lung cancer. Good disease control, very high, over 90%, very good safety result as well. So we're thrilled with that. We have another study, Codebreak 201, ongoing. So we think that this really supports that study, which again is in early line therapy in non-small cell.
I've heard a few times about KRAS at this conference. Tell me about what that is and how it works.
Yeah, well, so there are some master oncogene drivers of cell division. RAS, MYC are some of the examples. If you can control the activity of RAS in cancer cells, the hope is that you can really provide broad clinical benefit and that you can provide, real cancer control.
Right. And so tell me about your other abstracts, like what you mentioned.
Yeah, so again now for Lumakras, but this time now in colorectal cancer, in metastatic colorectal cancer. So we have another study called Codebreak 300. It's 160 patients with metastatic colorectal cancer. And here we see, again, remarkable results, a 2 versus 5.5 month improvement in progression-free survival. These are people with extensive disease. Very good safety profile. So again, just a very, very important finding. We think that Lumakras in this setting could be a new standard of care. So we think this is an important finding.
And sorry, which phase, how far along was that?
Yeah, so this is a phase 3 study.
Okay, so yeah.
In 160 patients.
So what has to happen before it becomes standard of care? What are the next steps?
Yeah, so we'll take the data, we'll obviously clean it, we'll file, we'll submit to regulatory agencies here in the FDA and around the world, and we'll have them do their very thorough review, and then hopefully it will get approved. Important as well, because we tested 2 doses, the 240 and the 960 milligram, and again the 960 milligram dose really does extremely well. In fact, the best dose in the study, so that's important too.
I'm hearing a lot at the show also about this need to balance efficacy with safety and the toxicity. So how does it do on kind of that measure?
Yeah, so the safety profile both in the lung cancer setting and in the colorectal cancer setting is as we've seen before. There are toxicities. These are all well described in the prescribing information because the drug is available in the non-small cell lung cancer setting. But it's consistent with what we've seen and very reassuring.
Did I hear that you guys just had a FDA clearance recently?
We did. So that actually is the second medicine that we could talk about, which is Imdeltra or tarlatamab.
Yes, Imdeltra, right.
Which is our bispecific T-cell engager that was just approved, accelerated review and approval by the FDA for small cell lung cancer. Now, we talk a lot about non-small cell lung cancer. Small cell represents about 15% of all of the cases of lung cancer. And so here in the US, there's about 35,000 patients a year diagnosed with small cell. It's usually treated with radiotherapy and chemotherapy. It tends to present late. It's fast growing, it's aggressive, and it presents late. So these patients will respond well initially, but they quickly relapse. And so there's a need for another therapy, and that is where Imdeltra comes in.
Got it. So small cell, it's less common, and also harder to treat? Or?
Yes, less common, 15% of all of lung cancer, but aggressive, fast-growing, and very hard to treat. And so in 2023, we presented data with Imdeltra, tarlatamab, in patients with extensive stage small cell lung cancer. And typically, these patients would have a median survival of maybe 3 to 5 months, so it's very aggressive. We were thrilled because we found in that study that median survival was tripled, over 14 months of median survival, which is another holiday, it's another birthday, another Christmas for somebody to see. What we have found with these bispecific T-cell engagers, we have another one called Blincyto that we use in ALL, a hematological cancer. So if you can move them into earlier lines of therapy, they may actually bring real curative capability. We see that with Blincyto. So our aim now with Imdeltra in small cell lung cancer is to move it earlier. We're committed to the patients. We're required, it was accelerated approval, so we're required to do more studies, and we're doing them. But we're excited, we're really excited about it. And the data that we're showing here is really in a subset of those patients that underpinned the approval, looking at people with stable brain metastases. Obviously, it's a harder group of people to treat. They tend to have worse prognosis, and we wanted to see how do they do, and the answer is they do very well. The safety profile is, as we saw in the overall study, and the overall response rate and disease control rate is also really high at 94%. So reassuring, and we think this medicine, Imdeltra, has the potential to be a true transformational medicine for patients with small cell.
So you have evidence that it is effective in earlier line, moving earlier, but also these patients with the brain metastases, they must be later. So it has kind of, you're researching both directions.
Yeah, so for Imdeltra, we have only studied it in the extensive stage patients. We are now going into earlier phase studies. It certainly appears to work well in the late stage patients with and without brain mets. What we're doing now is moving into earlier lines because with Blincyto, we've seen that the roadmap is as you move earlier, you can get really strong disease control and even curative outcomes. So it's really powerful.
If the more we start to see that, that some of these therapies work better earlier, is it always going to make sense to sort of start the research with the later stage patients, or is there going to come a point where we can kind of skip ahead when you have a promising drug? Or how does that tension play out?
I think I would say a few things. We have definitely seen the biology has advanced so massively in the past, even 5 years, that our ability to go after high validity targets that we really think play an important role in cancer development, progression, and metastasis pays off. So given that, I think it does make sense that you can go not only after late stage patients, but move really rapidly into earlier patients as well, where you can get your biggest benefit. We saw that with the Lumakras data, that when we go into the early stage non-small cell lung cancer patients there, we get really profound results.
Is there a challenge with recruitment? Is it harder to recruit the earlier stage patients?
I think regulators, physicians, patients want to know that, okay, we've tried the medicine, we have a reasonable safety database, we have a sense of how it's working. But then, as you say, it does seem that the model is, as you can go earlier now with these targeted therapies with high efficacy and acceptable safety, that you can bring real clinical benefit if you can get into those earlier stage patients rapidly.
So you mentioned that you've just recently arrived at ASCO, but I'm sure you've been tracking the abstracts and the data, and there's been a lot of action around lung. What are your impressions of sort of how your research fits into the larger trends here, I guess?
Yeah. Look, again, I would say, we've been in cancer research for 40 years. We're proud of that. We're proud of the fact that 1 in 5 cancer patients gets an Amgen medicine. For us, small cell and obviously non-small cell is a key focus. It's a disease stronghold for us that we want to continue in. We have many other medicines. We have medicines that go after 2 different pathways within one cell. We're looking at that in lung cancer. That's AMG 193. But we're broad. We have medicines across gastric cancer, across prostate cancer, and we're multimodal as well, from small molecules through to large molecules, and obviously, as we've talked about here, bispecific T-cell engagers.
Right, which would fall under cell therapy, or?
It's interesting, not quite. Although it pulls in, the beauty of the platform is it grabs onto a cancer cell, and it, with another arm, grabs onto a white blood cell, a CD3 cell, for example, pulls it in, and then unleashes in a very directed and powerful way the patient's own immune system to kill the cells and to bring about that clinical response.
So there's one question I'm asking everybody I'm talking to at the show. What advice would you have for a young professional entering oncology right now?
I think get strongly scientifically trained. Don't be in a rush to move quickly through a career pathway. Really deeply learn the science, really deeply learn the clinical medicine that you want to go and treat. And the other thing I would say is keep patients always at the center of everything you do. This is a huge meeting. There's so much going on here. For all of us, the North Star is to help patients live longer, better lives, and to help them and their families. We live that every day at Amgen, and I think that's fundamental to what young physicians should do today.
Absolutely. I think ASCO does a pretty good job of that. I've always been sort of impressed by their ability to center the patient, and I think part of it is the meaning of practicing oncologists. So
Yes.
These folks deal with the patients every day.
Yes.
It's a
humbling thing.
Any other thoughts on your mind, or anything you want to emphasize or reiterate?
No, look, again, I would say we're excited about both of these different molecules here, Lumakras, Imdeltra, and the great research that our colleagues at Amgen have been doing around the world to just bring these therapies to as many patients as we can.
So any other thoughts, anything else you want to share?
So look, it's a great meeting for us. We're excited about the Lumakras data there. We're also excited, obviously, about the BITE data with tarlatamab. And, just post the meeting, we're excited because Blincyto, our other BITE for ALL patients, we're hoping to get FDA approval in late June. 21st is our PDUFA date for that in first-line consolidation chemotherapy for those patients. So lots for us going on right now.
Fantastic. We'll keep an eye out for that.
Thank you.
Thank you so much.